Hi, everyone, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan Pelter.
And I'm Stacy Tsai.
And welcome. For those of you who are just joining us, welcome. And for those who are coming back, welcome back.
Today we have our special guest, Dr. John Evans. I'm happy to give you a little information about Dr. Evans. He's going to be talking to us about tachycardias and bradycardias today. So Dr. Evans is a clinical assistant professor at Stanford University. He received his medical degree from Wayne State University School of Medicine and completed his internal medicine residency at University of Pennsylvania Hospital. He then completed a fellowship in cardiovascular disease from Oregon Health and Science University, and then a subspecialty fellowship in advanced heart clinical cardiac electrophysiology from Stanford University. So we're very fortunate to have Dr. Evans today. So without further ado, I'm going to stop share, Dr. Evans, so you can give us your awesome talk.
Thanks for the introduction.
Perfect. I see your screen.
All right. So I'm going to talk about bradycardia and tachycardia. Let's get started. There's an old EP joke asking, what do you call an EP emergency? The answer is ACLS, and this used to be our joke to not need to take a call as electrophysiologists. But seriously, most EP emergencies can be dealt with ACLS. So that's really what we're going to want you to rely on. Like, one of my biggest suggestions for cardiologists is to continue to carry easy access to their algorithms, whether it's bookmarked on their smartphone or with the cards in their pocket. So ACLS really hinges upon figuring out whether people are breathing normally and whether their heart's beating normally. This is the key to everything that we're going to be doing. You know, it's nice to have the reversible causes easily accessible, but figuring out the stability of the patient first and foremost is very important. So let's start by going through a patient. So first patient I want to talk about is a 76-year-old who has a CRTP device. He presented with dizziness and feeling generally unwell. On the monitor, it revealed a heart rate of 188 beats per minute. His blood pressure was 92/53. He was afebrile and had normal mentation. You can see that what was happening was the patient was actually double counting. The defibrillator connected to the patient was counting the T waves and the QRS complexes, giving him a heart rate of 188, when really his heart rate was 94. He unfortunately was shocked for this. So the first key lesson in ACLS is, in this situation where you're looking at whether the patient's breathing normally and having a normal pulse, it's nice to check your own pulse too. Keep a cool head and really think through things. If things don't make sense, take a little more time, because it's very unfortunate when things like this happen. The second patient I want to talk about is somebody who will get us into our discussion on bradycardia. This is a 79-year-old who's post-operative day 2 after a TAVR. This patient went unresponsive with bradycardia, and the cardiology fellow was called. Fellow was told that there was CPR for 90 seconds, and now the patient is, quote, doing okay. After this event, the heart rate is 72, the blood pressure is 137/84, and there's a tracing from the event. You can see that patient essentially had no pulse whatsoever for a while. So going through the adult bradycardia algorithm, the hinge point here is also figuring out whether or not this patient is stable. Really, we're looking for manifestations of hypotension, acutely altered mental status, any signs of shock, ischemic chest discomfort, or acute heart failure. We're going to use these to drive our decision making. You know, the classic treatments are atropine, dopamine, epinephrine, and transcutaneous pacing. But we're going to talk a little bit about some other things we as the expert consultants may have to offer. Our expert consultation, which is referred to in the ACLS guideline, is where we come in. Things we're going to do, we're going to talk about where the bradycardia is coming from, whether it's coming from the SA node, AV node, how high up in the node that is, and what we should do. We'll obviously have a role in defining whether or not pacing is indicated. whether it's transcutaneous pacing to continue as a bridge after code situation's done, whether we place a temporary transvenous pacing wire, or whether permanent pacing is indicated. I think it's very, very nice to rely on the 2018 ACC AHA HRS guidelines on evaluation of patients with bradycardia, because things are spelled out very, very well in there in terms of indications for pacing. And there's some other really wonderful things in there, like other drugs that we don't pull out nearly as often that aren't in ACLS, but can have a very good role in medical management of bradycardia. These include isoproterenol, aminophylline, theophylline. The aminophylline and theophylline are often not thought of, but they have a very prominent role in neurologic causes of bradycardia, so they can be very, very helpful to us. Now, it's also important that when we communicate with each other, we're all using the same lingo. In cardiology, when we read the electrocardiogram, we're going to talk about what's happening both in the atrium and the ventricles. Often there is the same rhythm, or there's rhythm conducting from one chamber to the other chamber. But when there's not, we discuss both chambers, what's happening. You know, accelerated rhythms are fast, and they're not an escape rhythm. Like, that's something that's going faster than you'd expect, faster than 60 usually, faster than we'd expect for normal sinus rhythm. The same areas that get accelerated rhythms do get these escape rhythms, though, and we name them based on the place they're coming from. The escape rhythm usually identifies that the sinus node is going slower than the escape, or even has arrested and stopped, or that there's AV block and we're getting an escape. So most commonly we'll name an atrial escape rhythm, a junctional escape rhythm, or a ventricular escape rhythm, depending on where it's coming from the conduction system. AV block, which we'll talk about first, is when impulses aren't conducting to the ventricles when physiologically appropriate. Blocked early beats are not heart block. I'm going to bring this up a few times because this is one of the most commonly mistaken situations for heart block. Heart block itself can constitute first degree heart block, which doesn't block any beats, it's just a delay, second degree, and third degree heart block. I think it's very, very important for people to pay attention to the ventricular rhythm in heart block, because there are certain things that are going to have a regular rhythm. First degree heart block with a regular atrial rhythm is going to conduct with a regular rhythm. If you have N-to-1 second degree heart block, that's either 2-to-1, 3-to-1, 4-to-1, you're going to, again, conduct very irregularly. Third degree heart block has AV dissociation. The ventricle will have its own regular rhythm. The other second degree heart blocks, the key phrase is group beating, and you're going to see groups of beats, whether it's a pair of beats together in 3-to-2 heart block, or longer groups. We'll get into the periodicity of the intervals in just a moment. So just to review, first degree heart block is when the PR interval is over 200 milliseconds. This is not a cause of bradycardia in and of itself, but it can be an indication for permanent pacing if the P backs up into the T wave and the atria contracts against a closed AV valve. So I mention it here with the other bradycardias. Now, second degree heart block, type 1 or Mobitz 1 Wenckebach, has the classic pattern that people often describe as the lengthening PR interval. But in cardiology, we typically are going to define what's happening with the RR intervals. And so the hallmark of Wenckebach is actually RR intervals that are getting closer and closer together with any group of beats. This is actually because of a decrease in the change in PR. So within a group, the beats are going to get closer together. And in 3-to-2 heart block, you're going to have a longer RR interval than the blocked interval. And so twice the shorter interval is going to be longer than the longer RR. We'll get into that a little bit more in a minute, but I just want to go through the hallmark here. We have progressive PR prolongation. It can be very subtle late in a cycle of Wenckebach when the PR gets longer and longer. So the best place is to compare after dropped QRS, the first PR afterwards versus the PR before. It's markedly longer just before the drop beat. Typically, this implies that the origin of AV block is going to be at the AV node above the His bundle or the bundle branches. This isn't 100% though, but it's a general rule of thumb. Now, MOBITS 2 is going to have a fixed PR interval, which means with any group of beats, the RR intervals are going to stay the same. And when you have 3 to 2, your short RR, if you multiply that by 2, it's going to give you the long RR interval. Usually, this being lower disease, it'll conduct in a fixed ratio of 2 to 1 or 3 to 2, 4 to 3, unless the PP changes, making it harder for the conduction system to conduct. Wenckebach can have a little bit more variability and a couple levels of block, so you can have different patterns of how conduction is happening because it's vaguely mediated. This is usually much more fixed, so we're usually going to see the same pattern continuing over and over again. The origin of the block is usually below the AV node within the His bundle or the His-Purkinje system, so typically there may be some bundle branch block with this. This often progresses to complete heart block, so pacing is indicated for this even in the absence of symptoms most of the time. So I'd mentioned this before. When looking at these, I just want to bring up the example of something that's not second-degree heart block. You have an early PAC here causing this dropped beat. This is physiologic for this early beat not to conduct. So when you see this, you don't have to worry that this is MOBITS 2. This is just a non-conducted PAC. All right, 2 to 1 block is a special case. We can't tell whether it's MOBITS 1 or MOBITS 2 until somebody's interval of conduction changes. So often we ask people to do maneuvers. With vagal maneuvers, MOBITS 1 is already vaguely mediated. It will often get worse. Or if we do things to remove vagal tone, such as having the patient exercise, whether it's truly walking or just arm grips and isometric exercises, conduction will often improve because the vagal tone will lessen. In contrast, MOBITS 2 is dependent on the PP interval. When we do a vagal maneuver, the PP will often get longer as the heart rate slows and conduction may improve. Now, when the heart rate goes faster, it's harder for that to conduct and the block may get worse, in contrast to the MOBITS 1. Third-degree heart block, sometimes it's very, very helpful to label out what you see happening with the atrium and the ventricles to identify them. Here we see a rhythm consistent with sinus rhythm going approximately 100 beats a minute. And then we have a either junctional or ventricular escape, it's slightly wide, that's going at 50 beats per minute. So for third-degree heart block, there are a few criteria that we should know to confirm this. One is AV dissociation. The atria and ventricles should each be doing their own thing. Typically, we look at this in sinus to see what's happening because it's easier to find, but think of regularized atrial fibrillation. In that case, the atria is fibrillating and then the ventricle may regularize when it's dissociated because it's not listening to that irregular rhythm at the top. The atrial rate should be higher than the ventricular rate to demonstrate complete heart block. If there's an escape rhythm going faster, it may not be able to conduct. So we do not define heart block when the ventricular rate is higher than the atrial rate. And then finally, beats with adequate time to conduct do not. This is actually very, very important to see. P wave should scan diastole to make sure nothing comes through and brings in an early QRS. If you get an early QRS, there is some conduction. So this third rule makes it difficult to diagnose complete heart block when you have accelerated junctional or ventricular rhythm going on, or if things are marching out close in time with isorhythmic dissociation. So things that aren't quite complete heart block. Here we have high-grade AV block. This is treated similarly to complete heart block, but there is a variation in how beats are getting through. Sometimes there's more block than other times, but it is not complete because you have some conduction happening and you don't have dissociation of the atria and the ventricles. Again, this is an example of isorhythmic dissociation, not complete heart block. So here, the atrium is going just slightly faster than the ventricle, so you can see the P waves creeping out in front of the QRS complexes. But we don't call this complete heart block because even though the A's are faster than the V's and these are dissociated, there was never time for a P wave to conduct to the ventricle. Finally, accelerated junctional rhythms. This is something often we get a consult of whether or not there is potentially heart block because we have AV dissociation, but this is the example where the V is faster than the A, so not meeting that definition. Okay, going on to the other major cause of bradycardia, sinus node dysfunction. Sinus node dysfunction incorporates a spectrum from sinus bradycardia to sinus exit block to full-on sinus arrest. Usually when we talk about sinus node dysfunction, we're not mentioning just sinus bradycardia or sinus arrhythmia that are normal variants in either young or healthy people that have high vagal tone. There are some potentially reversible causes of sinus node dysfunction, including drugs that block the AV node, hypothyroidism, ischemia, hypothermia, or electrolyte abnormalities. I always like to remind people that I do have a selection bias because I'm an electrophysiologist, but I have seen hyperkalemia present more times with sinus arrest than I have seen it present with peaked T waves. So always be on the lookout for hyperkalemia if you do see sinus arrest. Typically, irreversible sinus node dysfunction can manifest as sick sinus syndrome. People can get tachycardia, bradycardia syndrome, where they'll have bradycardia as a response to tachycardia when sinus rhythm resumes. And always when you have a escape rhythm, even if it's a atrial escape rhythm that's got an axis different than sinus rhythm axis, that's going slower than 60, always think that there's a good chance that that could be sinus arrest. Okay, so going through the bradycardias from the sinus, we start with sinus bradycardia. This is sinus rhythm with a rate less than 60. Always look to make sure that it's sinus. You know, in V1, we're going to have a positive, negative P wave. In 1 and 2, usually we're going to have positive P waves. Once sinus bradycardia gets significantly slow, it could represent 2-to-1 sinus exit block. And looking at the trend of how things slow down, whether it gradually slows or if it jumps and cuts the rate in half, that can be a good way to identify 2-to-1 sinus exit block. So talking about the sinus exit block, this is where P waves are going to have a periodicity that are similar to the R waves in AV blocks. So you're going to have grouped beating in type 1, which is like Wenckebach. The P to Ps are going to get closer together, just like the R to Rs get closer together. And in type 2, the P to Ps are going to be fixed. This sinus exit block usually represents some scarring in the sinus node and is much more often to represent an irreversible cause of sinus node dysfunction. When people do have their sinus node dysfunction or AV block, we always want to think about vagal causes or sleep disordered breathing. You know, vagal causes and sleep apnea are a reversible problem, and usually we don't need to treat the heart in those situations. We just need to treat the underlying cause. There are several keys to look for when looking for vagal stimulation, but the biggest key is that you're going to be slowing down in both the sinus node and the AV node at the same time. I bring up criteria from a new scoring system to determine the likelihood of vagal event happening. But the bottom line is you're looking for sinus slowing at the same time of AV node slowing. Okay, and then finally, the last thing to think about when we're thinking about bradycardia is when do we need a temporary pacer? In general, temporary pacing is indicated when bradyarrhythmia causes symptoms and/or severe hemodynamic impairment, and when permanent cardiac pacing is either not immediately indicated, not available, or a high risk, such as a setting of infection. Permanent pacing indications are well delineated in the 2018 guidelines. And I think the easiest nutshell way to sum that up is all block below the level of the AV nodes. This is complete heart block or Mobitz 2 second-degree heart block that is below the level of the AV node, gets a pacemaker regardless of symptoms. Everything else, we just wait for symptoms. Previous iterations of guidelines would give time cutoffs or rate cutoffs, but there are absolutely none of those now. It is all defined by symptoms and hemodynamic compromise to get the pacemaker. In terms of temporary pacing, we're obviously going to think about doing that whenever a permanent pacemaker is indicated, but there are certain things when the optics really draws the need to get temporary pacing until permanent pacing is available. One of these things, the patient we had talked about was post-TAVR. When you're post-procedure and what you did may be the underlying cause, it is worthwhile to keep profound events from happening just for the look of things. Additionally, if you see an unreliable escape rhythm, if sometimes you get much longer periods without a reliable escape with heart block, or if you've got a wide escape with heart block, those would be reasons to put in your temporary pacemaker. They are relatively low risk, so I normally have people err on the side of caution and place a temporary pacer. Now, when temporary pacing is being done rather than permanent pacing because of the risks such as infection, sometimes we're going to use a permanent pacemaker lead to do a temporary pacemaker, and that's something that can be in for months, even externalized. It allows patients to ambulate and move about without a high risk of the lead dislodging. So we're going to come back to our second patient that we were talking about, the 79-year-old post-op day 2 after the TAVR. What's notable here is the patient gets one premature beat and then is in complete heart block with 0 escape. Now, this situation would fall very well under the category of profound symptoms. He got CPR. From the optic standpoint, given that this was so profound and he was getting CPR with a 30-second arrest, and that it's post-procedural, this is a patient who I would strongly suggest putting a temporary pacemaker in. In him, this was an example of complete heart block. This was likely related to the TAVR. Sometimes this is reversible, but until you get that sorted out, temporary pacemaker is indicated. And often, once somebody's a couple days out and having this, the vast majority of people are going to opt for permanent pacemaker in this situation. All right, let's get into tachycardia. Patient number 3, we're going to talk about. This is somebody presenting with a little bit of shortness, breath, and dizziness, heart rate 116, blood pressure 80/45. Now, the tachycardia algorithm, again, we still have the same questions of, is there any hemodynamic compromise? In people with ischemic chest discomfort, rising troponins, I always think about that as a falling underneath the relatively unstable arm and really think about cardioverting relatively urgently. And once we're looking at the tachycardias, we're going to separate them, whether they're wide or narrow, and secondarily, whether they're regular or irregular, in helping us decide how to treat them. Now, once you get through the code situation, there's the question of expert consultation. Sometimes people will be stable enough that we will be able to consult while they're still in their rhythm. Always try to get a 12 lead of the rhythm and run rhythm strips if you do any maneuvers, adenosine, or pushing any drugs, because it's very, very helpful getting a formal diagnosis by seeing this. Guiding appropriate cardioversion is very, very helpful. The ACLS guidelines say consider sedation in the patient who has somewhat stable tachycardia. Very strongly, you should consider sedation, because when a patient gets a shock, they typically will perfuse their brain from the increase in their intrathoracic pressure. If they are mentating at all, they will be mentating even better immediately upon receiving the shock. And pain, unfortunately, travels on unmyelinated fibers. So the pain is going to arrive after their brain has reperfused. And so people will feel their shocks, even when they're seeming like they're barely mentating at the point when you're deciding to shock them. Energy selection, normally we recommend manufacturer's highest setting. It will lead to less shocks and more successful initial cardioversion, so less shocks being needed. Part of the expert consultation is helping guide appropriate drug choices. This can be both helping out in deciding what to use as an AV nodal blocker in the setting of a patient with questionable hemodynamics, also can be in helping the selection of antiarrhythmic drug. Pretty much everyone who's going to be picking the drug to use in the hospital is usually going to be picking amiodarone. And so as the expert consultant, we may have a chance to avoid the use of amiodarone if there is a better option. Finally, our job is going to be to determine the mechanism of arrhythmia to further guide the treatment. So speaking of the mechanisms of arrhythmia, let's just run through quickly several of the causes of tachycardia. So a narrow, complex, regular tachycardia would be sinus tachycardia. Usually this is sinus rhythm with a rate of 100 beats a minute. Usually represents a systemic process driving the rate, whether it's pain, infection, PE, hyperthyroidism, drugs. The mainstay of treating sinus tachycardia is actually to treat the underlying cause, although there are some electrical causes of sinus tachycardia that are inappropriate. Multifocal atrial tachycardia is an irregular rhythm. To diagnose this, we need 3 different P wave morphologies in a 10-second rhythm strip. Typically, we're going to have 3 different P morphologies with 3 different PRs as well, because the different atrial foci are coming from different distances from the AV node. It's frequently associated with COPD, so it can be very, very difficult to treat if there's ongoing lung disease. Atrial fibrillation, again, another irregular rhythm. This is different in that there are no discrete P waves, there's fibrillatory F waves. Sometimes these will be too fine to see. Irregularity, I encourage you to use your calipers, especially when things get very fast. It can be very, very difficult to tell that things are truly irregular, but it's typically irregular, so all of the intervals will be a little bit different. Flutter. This usually occurs, typical atrial flutter with an atrial rate of 300 beats per minute. Often the second flutter wave is going to combine in with the QRS, be a little more difficult to see. So if you see a heart rate of 150, I always suspect that there could be underlying flutter with the sawtooth waves underneath. 2-to-1 flutter very often presents with a heart rate of 150. Often it'll get called sinus tachycardia, but you'll notice if you look at a trend view on telemetry, you're going to have a quick jump up to the 150 and sort of a rhythm that's stuck there. All right, other narrow complex tachycardias. In general, I encourage you to lump together narrow complex SVT. This is usually going to be AVNRT, AVRT, or AT. The things we see on the EKG can change the likelihood of one diagnosis versus the other, but it's very, very hard to nail definitively the diagnosis based on a 12-lead. When we record the 12-lead and rhythm strips, doing adenosine can be very, very helpful, because if you can see P waves keep going, then it's going to let you know that it's an attack. But apart from that, it's very, very difficult to determine what's what, other than giving you a percentage chance. So for example, here, the P wave is much closer to the QRS afterwards. So this would be a short RP tachycardia, which is going to decrease the likelihood of AT, but doesn't definitively give a diagnosis of one versus the other. AV nodal reentrant tachycardia typically is a narrow complex tachycardia with retrograde P waves. Normally inferior leads will have these inverted P waves because they're moving away. Additionally, the P waves will be narrower than the sinus P wave. AVRT is got an appearance very similar to AVNRT. One thing that can be helpful is to look at the 12-lead EKG. Delta waves on 12-lead can really give you the hint that patients have Wolff-Parkinson-White and a setup to have extreme tachycardia if they go into pre-excited atrial fibrillation. Now, abnormal rhythms coming from the ventricles, PVCs can come single in pairs and in triplets. Once you get to a triplet, this counts as non-sustained ventricular tachycardia. Sustained ventricular tachycardia, again, is a broad, usually regular rhythm, and sometimes you can march out AV dissociation, such as on this EKG. You won't always see that. You can get one-to-one retrograde conduction, so it's a little bit difficult to sort out. Torsade, this is a rapid rhythm that is usually pretty easy to recognize when it's happened. Patient will be totally unstable, predisposed by long QT. VF, sort of similar to Torsade. I always make the comment, this is also known as sudden death. So ischemia, structural disease are two big things to be looking for whenever we see people have this. Obviously, we're treating electrically and trying to prevent this from happening again. The big question that comes for us is, hey, is this rhythm that we're looking at VT or SVT with bundle branch block? So I think it's very important. Always try to find an old EKG if you can. Wide beats happen due to aberrancy, beats coming from the ventricle, or due to pre-excitation. Aberrancy and pre-excitation can sometimes be identified on old ECGs, and isolated PVCs can be seen on old ECGs that sometimes are going to match the shape of the run of a VT. So old ECG is very, very helpful. The other thing is knowing the definitions of right bundle branch block and left bundle branch block that can be found in the 2018 bradycardia guidelines or in the ACC AHA consensus statement, part 3 from 2009 on electrocardiography. These definitions are very, very helpful if your wide complex matches the definition for complete right bundle or complete left bundle. There's a very, very good chance that you have aberrancy as your cause your wide rhythm. And then there are algorithms that can help. So in this previous case that I had presented, again, old EKG that shows a left bundle looking similar to what you have in tachycardia can be very, very helpful. But in other cases, the different algorithms we use can be very helpful. So commonly used one is the Brugada 4-step algorithm. We basically look for an absence of an RS complex in all the precordial leads, an RS interval in one lead that's over 100 milliseconds, AV dissociation, and then we use some morphology criteria. Just going to go to our patient number 3, where we were looking at their EKG with presentation. Now, going through the steps, we're looking at the precordial leads. We're looking for lack of an RS. So step 1, we have an RS present, so that doesn't give us a diagnosis. We look for an RS over 100 milliseconds, which we have here in lead V2. So from the start of our RO wave down to the nadir of RS, we are at 150 milliseconds. So this is going to favor VT. Whether or not we see AV dissociation, we don't need to go to the morphology criteria because we've already gotten this as our favorable diagnosis. The Vereckei AVR algorithm can be very helpful. We're looking only at AVR, and we look for either an initial R wave, the width of an RRQ over 40, notching on the downstroke of a QS, ventricular activation that initially is slower than later. And again, our patient number 3, same person, we're looking at AVR only. There's no initial tall R wave, but there is a little R initially that is well over 40 milliseconds, which is going to favor VT. It's not a QS morphology, but just to give the example of the VI, VT, the VI, we're looking at the initial portions of the QRS here in the first 40 milliseconds. And in that first 40 milliseconds, we are only moving up a half a box. And in our last 40 milliseconds of the QRS interval, we're going up at least 2 boxes. So the terminal forces are greater, so that would favor VT as well. Finally, there's a newly published last year algorithm that is the limb lead algorithm. I'm going to skip over the lead 2 one. So the limb lead algorithm published in 2020 basically is looking for monophasic R in AVR or predominantly negative QRS in 1, 2, and 3, basically telling you you have a northwest axis, or opposing monophasic complexes in the limb leads. So here we don't have an R in AVR. It's not negative in 1, 2, and 3, but we do have opposing QRS forces in the limb leads. You have a monophasic negative complex in 2, 3, and AVF, and in 2 of the 3 other leads, 1 in AVL, you have monophasic positive complexes. So these all favor VT. So back to this patient, this patient was given an amiodarone bolus and converted to sinus. His heart rate was then 85, blood pressure 102/64. He was referred to EP consultation per the guidelines. This was the expert consultation that was done after his antiarrhythmic infusion. And there may have been other things that could be used. Let's talk about that a little bit. There are changing recommendations. Previous to the 2020 update, it was usually amiodarone alone, but they've added lidocaine for unstable arrest, and now stable arrest says amio or procainamide or sotalol. Part of this is because the labeling of amiodarone says every effort should be made to utilize an alternative agent first. Obviously, drug's not labeled for arrest. It's labeled for ventricular arrhythmia. So in arrest, it's very reasonable first choice to use. May be more effective than lidocaine, although there's some conflicting evidence. But once in a stable patient, you are using it on label, and the label says you should think about other things. And now the ACLS guidelines say to think about either procainamide or sotalol. These can be very, very good options to potentially treat the patient, and they will get out of the system quicker if we need to study the patient or do another treatment. So take-home points, basically keep a cool head following the ACLS guidelines. Don't react too quickly to numbers and things. Check the patient out, take a deep breath, and sort out the stability of the patient and how appropriate emergency treatment is. Rely on the ACLS algorithms. For bradycardia, determine your level of block, rule out reversible vagal causes. Symptoms or the inability to treat something because the heart rate's going too slow are going to be your big indications for treating bradycardia. For tachycardia, again, we're going to start out sorting out unstable versus stable, and sorting wide versus narrow helps us figuring out what to treat with, and like there are algorithms to sort out SVT versus VT. So hopefully with some of these lessons, it's a good jumping off point for feeling a little more prepared with arrhythmia. Thanks.
Dr. Evans, thank you so much. So many pearls and extremely high yield. I think, definitely a lecture that I wish I had as a incoming first year fellow. So thank you so much. So for people listening, please feel free to email both Megan and I your questions for Dr. Evans, and we will record a separate Q&A session to answer your questions. You can reach us at our email. So for Megan's email, it's pelter, P-E-L-T-E-R .Megan, M-E-G-A-N @scripshealth.org. And you can reach me at tsai.stacy, S-T-A-C-Y, also at scripshealth.org. Scripps Health is spelled S-C-R-I-P-P-S, health, all one word, .org. And we'll be sure to forward your questions to Dr. Evans during the Q&A session and have those posted for you. So thank you again, Dr. Evans.
Yes, thank you, Dr. Evans. Excellent presentation. And we look forward to the Q&A.
We'll see you then.
See you then.